Acetazolamide in lithium induced nephrogenic diabetic insipidus. Definitions. The most common cause of carrying nephrogenic diabetic insipidus is long-term lithium treatment. The management of lithium induced nephrogenic diabetic insipidus is challenged, even when the drug is discontinued and therapy initiated to try diuretics and reduce sodium intake. Ameliorating the inhibits lithium entry into renal collecting duct cells through the epithelial sodium channels. The side directives and low sodium diet result in hypovolemia-induced activation of the renin-angiotensin system, which stimulate proximal tubulus sodiums and moderate exertions, resulting in less volume delivery to the distal nephron. Diabetes insipidus.
Diabetes insipidus is associated with inadequate arginine vasopressin, also known as antidiuretic hormone secretion, or the renal response to antidiuretic hormone. So polyuria, dilute urine, and increased thirst are characteristic of diabetes insipidus. The hypothalamus is the region of the brain involved in coordinating the physiological responses of different organs that together maintain homeostasis. The hypothalamus have neurons running towards the posterior pituitary, which produce neuropeptides and will release them into circulation. These neurons are called magnocellular neurons, and they produce the hormone vasopressin, also known as antidiuretic hormone, abbreviated ADH. It will secrete ADH into circulation via the posterior pituitary. Antidiuretic hormone targets the distal part of the nephrons to increase channels, which will result in water retention. The nephrons is made up of the Bowman's capsule, the proximal convoluted tubules, the loop of Henle, the distal collecting tubules, and the collecting ducts. The afferent arteriole carries blood into the nephron, forming the glomerulus. The glomerulus will filter blood into the nephron. So water and sodium enters, for example. Water continues along the nephron tubule. 90% of the water gets reabsorbed back into circulation at the proximal convoluted tubule via aquaporin type 1 channels. The reabsorption of water back into circulation is actually the reabsorption into the vasorecta, which is the continuation of the glomerulus and the efferent arteriole. The vasorecta here in orange functions actually to secrete and reabsorb things from the nephron tubules. The remaining 10% of water in the tubule continues through the loop of Henle, the distal convoluted tubules, and the collecting ducts. And it's here at the collecting ducts where the remaining 10% of water can be reabsorbed in response to ADH. Now,
Lithium and nephrotoxicity. The kinin. The internal structure of the kinin. Lithium is the main nephrotoxic defect in the collecting duct. The collecting duct, under normal conditions, sodium enters the via epithelial sodium channel and is poured through the side throat. Lithium crosses the apical membrane and enters the side through the epithelial sodium channel. When the lithium enters, it prevents sodium from entering and improves the flow of sodium avalanche of the fluid. Lithium inhibits GSK3 beta intracellularly. Application in nursing. Recent data from animal models for lithium-induced nephrogenic diabetic insipidus show that hydrochloroleucine reduces polyuria in mice, lacking the dye-sensitive sodium chloride contrast pattern, which suggests that the mechanism of action of the drug may be mediated by carbonic anhydrase injections. Acetazolamide monotherapy was effects at the combination hydroxyl and amyloid in the reducing polyuria in animal model of lithium-induced nephrogenic diabetic insipidus but had fewer side effects. Pros and cons. Acetazolamide reduces the glomerular filtration rate by means of tuboglomerate feedback and reduces renal postglandular secretions. Bad effect note polyuria induced by nephrotic diabetes insipidus. Encouraged but these findings with administering acetazolamide to a patient with severe lithium-induced nephrogenic diabetic insipidus that was resistant to hydrochloride treatment and other methods. Here we report findings on the efficacy of and rapid response to such intervention.
Hey everyone, it's Sarah, the registered nurse, RN.com, and in this video, I'm going to be going over the differences between SIADH, the syndrome of inappropriate antidiuretic hormone, versus diabetes insipidus, also called DI. I know a lot of people get these two conditions confused, so what I want to do for you is I want to break down the key concepts you need to know for NCLEX and for your nursing lecture exams. So what I'm going to do is I am going to explain how the antidiuretic hormone works, the ADH, because if you can understand that concept, all of this other stuff, like the causes, the signs and symptoms, and the nursing interventions will make complete sense. So after this lecture, I highly encourage you to go to my website, registerednursern.com, and take the free quiz. A link should be popping up in a card to test your knowledge on the differences between SIADH and DI. So let's get started. Okay, the key player in these two conditions is called the antidiuretic hormone, ADH, also called sometimes as vasopressin. This hormone plays a huge role in SIADH and diabetes insipidus, and they work in the opposite of them. In SIADH, you're going to have an increased antidiuretic hormone. In DI, diabetes insipidus, you're going to have a decrease. So first, let's figure out the function of this hormone, because if we know what it does normally, then it'll help us understand what happens whenever there's too much of it or there's not enough of it. Okay. First, what is the function of ADH? What it does is it plays a major role in regulating the amount of water in the body. So it likes to keep your body nice and level with its water. And it constricts blood vessels. So how does this do this? Okay, what system, ask yourself, what system in the body helps regulate how much water we keep and how much we lose? The kidneys. So it accomplished this with the kidneys. And what ADH does is it causes the renal tubules to retain water whenever it's being released. So that's how it does it. So for instance, say that you have a lot of antidiuretic hormone in the body. It's going to cause those renal tubules to keep water. So you're going to have increased water in the body. Getting rid of it. But if you don't have a lot of the ADH hormone, antidiuretic hormone in the body, it's going to cause the kidneys to be like, hey, let's just get rid of this, and you're going to be losing too much water. And we'll go over this in depth here in a second. But let's look at the brain, because areas of the brain are responsible for regulating your antidiuretic hormone. Okay, in the brain, you have your thalamus, and right below the thalamus, you have the hypothalamus. That's where hypo comes in, below. So it's right below the thalamus. And the thalamus is responsible anti-diuretic hormone. So it also plays a role in thirst. Whenever you get thirsty, your thalamus kicks in and says, hey, let's make the body have the urge to get something to drink. Now,
The nephrogenic diabetes insipidus. There are three types of nephrogenic diabetes insipidus: genetic, acquired, or drug-induced. What's the cause of genetic nephrogenic diabetes insipidus? 90% of cases are due to X-linked recessive variety with mutation in the vasopressin 2 receptors. And when does it present? Unlike the genetic form of the central diabetic insipidus, the nephrogenic genetic form typically presents in infancy. Dehydration and hypernatremia can lead to seizures and mental retardation. The ureters are dilated due to high urine flow. And how the diagnosis is done: high plasma ADH with polyuria and hypotonic urine with hypernatremia. Autosomal dominant and autosomal recessive forms of nephrogenic diabetes insipidus are due to the mutation in the aquaporin 2 channels. The acquired forms of nephrogenic diabetes insipidus. What are the most common causes of acquired NDI? Hypercalcemia and lithium are the most common causes, lithium in 20% of cases. The other causes are renal tubular diseases, pyelonephritis, analgesic nephropathy, hypokalemia, amyloid sarcoid histiocytosis, and multiple myeloma, papillary necrosis, or osmotic diuresis. What are the drugs that cause nephrogenic diabetes insipidus? The mnemonics is meal, MEAL, methoxyflurane, ethanol, amphotericin, and lithium. What are the antibiotics that cause nephrogenic diabetes insipidus? Demeclocycline, which is a tetracycline group, rifampin, and aminoglycosides that include gentamicin and kanamycin. How to distinguish between central and nephrogenic diabetes insipidus? After 1 to 2 hours, desmopressin increases urinary osmolality by at least 50% in CDI, but will not change in nephrogenic diabetes insipidus. Treatment for nephrogenic diabetes insipidus is hydrochlorothiazide combined with potassium sparing amiloride. Indomethacin may also act. So how does the thiazides act? The thiazides decrease the distal tubular reabsorption of sodium and water. So it decreases the GFR and increases the absorption of sodium and water in the proximal tubule. So thiazides decrease sodium and water reabsorption in the distal tubule and increase sodium and water reabsorption in the proximal tubule. So less fluid reaches the distal nephron, so overall fluid conservation is obtained.
Conclusion. Pneumonia embarrassing effects were noted during therapy, which extended up to the patient's discharge 6 weeks after admission. At the time of hospital discharge, he had mild metabolic acidosis and hypokalemia. Our experience documented successful use of acetazolamide in patients with lithium-induced nephrogenic diabetic insipidus and supports findings in animal models. Diabetic insipidus.
Welcome back. Today we'll talk about diabetic insipidus. Diabetic insipidus refers to ineffective antidiuretic hormone, which results in inability to concentrate urine. ADH is secreted from the hypothalamus, so if the secretion is decreased, we call this central diabetic insipidus. And it works on the kidneys, so if the receptors are defective in the kidneys, we call this nephrogenic diabetic insipidus. cause for central diabetic insipidus is basically anything that can damage the brain and decrease the secretion of ADH. The diagnosis is basically made by imaging studies where we see damaged brain, or by administering ADH and reversing the pathophysiology of central diabetic insipidus. In other words, if administration of ADH results in concentrated urine, this is the central type. The treatment is ADH analogs and hydration. Nephrogenic type is caused by damage to the receptor of ADH, which can be caused by hereditary receptor mutation or medications such as lithium. The diagnosis of nephrogenic type is made when the administration of ADH does not result in urine concentration. The treatment of the nephrogenic type is a little bit tricky, so I'm going to try explaining each medication as we go on so you can memorize them better. Thiazides are used because even though they are diuretics, they cause concentrated urine. NSAIDs are used because they break prostaglandin, which normally breaks ADH. So NSAIDs salvage whatever ADH we have left. Amiloride is especially effective in lithium-induced diabetic insipidus, and it doesn't hurt to give hydration and salt restriction. And here's a small quiz for you. So how do we conduct water deprivation test? And here's the answer. Alright guys, that's everything I've got. Hopefully this is for you. Thanks again for watching, and I'll see you guys later.
Issue happening in Ecuador. A 49-year-old man with bipolar disorder requiring long-term lithium therapy was admitted for electric craniotomy for a left acoustic normal leakage in the cerebellophone-topic angle. He was unable to drink water despite dilute polyuria. The serious sodium lipid range from the 155 to 164 mol per liter, and the urinary osmolality from 94 to 105 per kilogram of water. Lithium was discontinued, and 5% disproved solution was administered intravenously. The urinary osmolality and serum sodium level did not respond to desmosterone administrations, and the finding that is consistent with complete nephrogenic diabetic insipidus. Thank you, everyone.